Okay, so we've gone from the parasympathetic nervous system, which is your feed and breathe part of your autonomic nervous system, and now we're going to be heading into our sympathetic nervous system, which is more of our fight or flight, our need to flee kind of a system. And again, we talked about the importance of having both a system that allows you to rest and digest, and now we're going to talk about the system that will make you go, 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 go. Next slide. Learning outcomes. Again, use the helpful symbols as we go through the lecture series to find your way. More. Here we go. Sympathetic nervous system, your fight or flight response. This is your get up and go. This is the what that we've been waiting for. This is the system that helps to prepare you to be able to flee from danger, fight tigers, do whatever it is that you need to do in order to be able to get away from the danger. When we talk about your sympathetic nervous system, we're really kind of talking about this pathway. Okay, so the brain says, hey, something's going on. Activates the acetylcholine. The acetylcholine goes, no problem, boss, I got you under control. And it runs down to the sympathetic nervous system and it activates norepinephrine and epinephrine and says, hey, we need to get to the adrenergic receptors. Now, we have a lot more receptors in our sympathetic nervous system than we did in our parasympathetic system. As you can see, they really break them down really, really far into a whole bunch of different ones. What's going to be important for us to realize as nurses is where all these receptors are at and what they are physically doing to the body when we turn them on or we turn them off. So again, this is what your body does in order to get you ramped up and ready to get away from the lion in the room. So here we go, little chart here showing the sympathetic division and the parasympathetic division side by side. I'm telling you guys, you're going to learn to live by this chart, okay? There's a pretty little poster, okay? I make myself a pretty little poster every semester when I teach pharmacology to help myself remember. I put the parasympathetic nervous system on one side, I put the adrenergic response, the antagonistic response, and on the other side, I put the agonist response so that I can remember which way I'm going, all right? So again, here's your pretty little chart just to kind of help get everything kind of squared away in your brain and where all these different receptors are. I highly suggest that you take one and you make it your own, but in case you're running low on time, I did provide one. When we talk about sympathetic nervous system medications, we talk about medications that are agonist. We talk about medications that are antagonist. So when we say antagonist, we can also call them blockers. Sometimes that's a little bit easier for me to remember. That's going to block that reaction. I just want you to remember this. When we're talking about agonist, we're talking about what the body is normally doing whenever that system is activated. So say, for instance, I look at my chart and let me get to my correct one, the sympathetic nervous system, and I say I'm going to have an agonist response. That's medication's going to cause the body to do what it's programmed to do. So in the case of an agonist for our sympathetic nervous system for alpha-1 and our eye, that would cause it to dilate, make it really, really big, right? The antagonistic response, the blocker response, would be that it would make the pupil really, really small, more like the parasympathetic response, right? So that's what we have to help get into our brains is the chart. Chart, 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 chart. What's happening whenever these things are happening? I'm a big visual learner, so to me, the more pictures you can give me, the better off I can remember this. I will tell you that I got a hold of this picture when I was in nursing school 20 years ago, and it stuck with me ever since. So this is just kind of one of those pictures to help you remember where your beta-1 cells, beta-2 cells are. So again, your heart, you only have one heart, and the letter B fits in the top. And then with the lungs, you've got 2 lungs, and so that's your beta-2s. So again, just those little small tricks to help stick that stuff in your brain. If you come up with something really cool, please share it with us in our class time or online or in our class. That way we'll know and we can use that information to help it stick in our brains better. Okay, beta-1s. So what happens whenever we activate a beta-1 receptor? We get an increased anterior atrial and ventricular conduction. We get the electrical impulses actually increase between the top side of the heart and the bottom side of the heart. I get an increased tone in the cardiac system. So it sets up and it's like, okay, let's make this happen. And then I get an increased renin release. that renin release actually comes from my kidney, okay? But when I have an increased amount of renin in the body, it tells the body to hold on to fluids and will help to ultimately increase my blood pressure. And I can actually speed up the heart rate by giving someone a beta-1 agonist. So when would I use a beta-1 agonist? Okay, well, if my patient's got bradycardia and their heart rate's in the 30s or the 40s or the 50s, we're going to give a beta-1 agonist, something that's going to increase the heart rate. If a patient's got heart failure, we may give them a beta-1 agonist if they're really, really sick to help to increase the pumping ability of that heart. And a patient who has shock, who is decompensating, we may give a beta-1 agonist. I'll tell you that those agonist kind of qualities of a beta-1, those are really going to be reserved for patients who are extremely sick and are in like a ICU. So when I think about giving someone a beta-1 agonist, the one drug that I think about, I'm like, ooh, that would work. It's epinephrine. Okay, they call it epinephrine. It has a bunch of different dosages with it, or strengths with it. But that's the kind of drug I would think. I will tell you that in nursing, for the most part, in our day-to-day nursing, wherever our patients are, I'm usually looking at a beta-1 agonist. We also call those beta blockers. And I'll tell you, we're probably going to call that a beta blocker far more often than we're going to call it a beta antagonistic drug. With these medications, we would see these given for beta blockers would be given for an acute MI, patients who are angina, patients who are having high blood pressure, patients who are having dysrhythmias. I will also tell you that there is some off-label uses of beta blockers. You'll see beta blockers given to people who are anxious. You'll see beta blockers given to patients who have migraines. So there are some off-label uses that you'll see, and they work really well. So for our beta-2s, remember that little slide we saw a couple went over earlier, you've got 2 lungs, so beta-2 is found in your lungs. This is what happens when we activate or we make beta-2 work for us. We get bronchodilation, increased blood glucose, relaxation of the bladder, relaxation of the ciliary eye muscles, and then relaxation of smooth muscles, and relaxation of uterine contractions, or I'm sorry, relaxation. So when would I use this medication? Well, I would use it as an agonist for allergic reactions, asthma, COPD, and preterm labor. We don't really have a reason to use a beta-2 blocker so much as we use the beta-2 agonist. So you'll see those quite frequently in practice, but not so much a beta-2 blocker. We'll use an agonist on that one. Okay. Beta-3s. So beta-3s have, they conduct lipolysis, they break down fats, they relax part of the bladder muscle, and then they work with thermogenesis. We don't have a really good beta-3 blocker use for anything, but I'm hoping that one day, you know, they figure out how to activate beta-3s and then it'll eat all my fat cells. I mean, that would be fantastic. They also think that beta-3 probably has some cardioprotective effect, but the science is still out on that. So eventually we'll get there. We're going to learn a lot more in the next 5 to 10 years about beta-3s, but right now our main uses is just for an overactive bladder, which, hey, nobody likes to pee. Alpha-1. So our alpha-1 helps to close the bladder sphincter. It increases peripheral resistance, causes mydriasis, which that's the big word, so that means that it's going to dilate your eyes, and causes vasoconstriction. We use these qualities, especially whenever we start talking about allergic rhinitis. Whenever all of the blood vessels in here get really, really engorged and they're real fat, it won't allow air passage to go back up and down your nostril because your airway should be like this, but because all the tissues are so swollen, it's like this. So what an alpha-1 agonist will do is to actually dilate the nasal mucosa and allow all of the air to go through there, okay? An ophthalmic hyperemia basically is like a blood vessel in the eye that's ruptured. You can Google it. It's pretty cool looking. We do use these medications, the blockers, an alpha-1 blocker, to help to treat benign prostatic hypertrophy and also hypertension. So just a quick fact here about alpha-1 blockers. So alpha-1 blockers are known to cause some pretty incredible hypotensive episodes. So if you have a little old man who's having problems peeing because his prostate's gotten too big, and we give him an alpha-1 blocker, we may treat his blood pressure problem at the same time. The orthostatic hypotension that comes with alpha-1 blockers, it is really incredible. it is so bad sometimes that they will actually tell you to administer the first dose in the office so that you can monitor them to make sure that they don't have an adverse reaction. So just to think about. All right, let's talk about our next ones. Oh, this is supposed to say alpha 2. I apologize. That slide is not correct. So please take out your pencil and write down, scratch out the 1 and write alpha 2. All right, good job. Here, we can do it here with our stuff too. Let me see. Okay, that's actually alpha 2. Okay, so with this medication, it actually is kind of interesting because an alpha 2 blocker actually works in the brain to work about how to release norepinephrine from the brain to do or not to do. So an agonist, we would actually give a patient an alpha 2 agonist to help to control hypertension. For those of us who are in clinical practice right now, you may be going, what drug is that? That would be clonidine. Clonidine is one of the only medications that actually works in the brain in order to help to control hypertension. Now, the antagonistic side of this, an alpha 2 blocker, would actually be used to help to treat erectile dysfunction. As part of our practical application, whenever we're learning about medications, we kind of have to go through the same process over and over again in order to get a process in place. What I mean by this is this. When you were learning to ride a bicycle, someone had to tell you every step of the way how to do it over and over again. And you kept doing it, and then someone would have to tell you the steps over and over again. But now if I told you to go ride a bicycle, it's second nature. You got it. This is what we need to do with this nursing process application. Right now, while we're establishing these practices, I need those of us who are in practice, those of us who are going into practice, to develop a process for giving medications the same way every single time. That way it becomes innate and it becomes part of your practice, part of something that you do all the time. So for instance, whenever we're doing the nursing process application here, the first thing we're going to do is we need to assess our patient. So we've got a medication order, we've assessed that, we need to stop, we need to look at the patient's health history, we need to say, is there anything in that health history that would make me not want to give this patient this medication? Is there anything in the lab work that is wrong that would make me not want to give this patient this medication? Are the vital signs stable that I can give this patient this medication? Are they appropriate? What about the cognitive ability of the patient? Does the patient understand what we're doing? Does the patient understand what's fixing to happen? Okay. And then once I'm giving the medication, I go through the process of I scan the armband, I check the date of birth, I'm looking at the patient's name, I've got the medication, I verify the medication when I pull it out of the medication dispenser. I make sure that I've checked it against the order. I'm making sure that when I'm in the room that I'm checking it against my MAR. I'm checking, and then I'm really ready to give the medication. I'm telling the patient what the medication, the who, what, when, and where of that medication. I'm making sure that I know in my head how the drug book says to give that medication, okay? And then once I give that medication, what do I need to do after I give it? Is it just, hey, I gave the medicine, I'm out of here? No, that's not what's going to happen, because you are responsible for what happens after that medication as much as you are responsible for giving that medication. So how often, based upon the medication that I'm given, do I need to reassess this patient? Okay, is it every 15 minutes, every 30 minutes? It all depends on all those factors that we've already learned about onset of medication, duration of action, how long is this medication going to affect them? How is it going to affect them? I need to know about side effects. Okay, guys, listen. When we're starting drug cards, don't write it down that a medication causes GI side effects unless it is just really, really bad, because they can all cause GI side effects, okay? So don't try to stick that. You're like, oh, it's going to cause nausea and vomiting. They all cause nausea and vomiting. So instead, what are the side effects that are specific to that drug? We just talked about alpha 1 blockers and how they treat for hypertension and how those medications cause severe hypotension. That's a fact that I need to keep in my brain before I go in there and give that medication to that little old man, okay? Always assessing, did this medication work like it was intended to work? So we're going to have 2 prototypes for this time. We're going to do an alpha adrenergic blocker that is specifically selective to alpha 1, and we're going to be looking at prazosin. This is one of those ones that you need to make a drug card on. Then the other drug that I want to highlight is called epinephrine. Your book gives neosynephrine, which is philo something or other. I don't like to use that one as my prototype drug for a drug to represent the agonist class because it's actually only selective to certain receptors on the autonomic nervous system. So I prefer to use epinephrine because it is selective to it is non-selective. It's going to hit every single receptor in the sympathetic nervous system. So it's way easier to remember and it's way more practical because I will tell you we give epinephrine more in the hospital than we give the neosynephrine. So make a drug card for epinephrine, make a no drug card for prazosin. So this is a patient that we gave a medication to. And this is the effects of that. So the picture is a little bit brutal here, guys. So if you've got small children, you may want to have them step away. But essentially what happened was we were trying to keep this patient's blood pressure elevated. So we gave epinephrine. We even put them on a drip called Levophed, which acts a lot like epinephrine. And one of the things that happened is that as the patient's blood vessels became more and more constricted because we're trying to raise the blood pressure, we actually began to get necrosis of the fingertips and fingers that then caused this patient to actually lose their fingers. So we have to be very careful with epinephrine when we give it, IV or other routes. I will tell you that frequently in the hospital, you'll see them use epinephrine. You'll see them when they go to suture. We'll use lidocaine and epinephrine mixed together to implement sutures. The reason they do that is because the epinephrine closes the blood vessels off so that we have less bleeding into the wound. The problem you have is that it has less bleeding to the fingertips and other areas of the body, and you can get this type of a reaction. So what a physician told me one time, there's a couple of places that you'll never mix lidocaine and epinephrine together in order to do sutures. You never do it in the nose. You never do it on the lobes. You don't do it on the fingertips, the toes, or anywhere near the hose. Yeah, I said it, the hose, okay? So nose, lobes, fingertips, toes, and nowhere near the hose, okay? We would not use lidocaine and epinephrine together because of the risk of vasoconstriction, which could cause the nose, lobes, fingertips, toes, or the hose to fall off. All right, guys, that is everything for your sympathetic nervous system that you need to know for now. Make sure you read your book. We will see you guys during the next lecture series.